All right, if somebody was going to take the fat out of your body and shoot it inside your joint alongside a ligament or tendon, it may sound a little unusual, but that's what I'm going to talk about today. I'm Dr. John Tait, non-surgical orthopedic doc, regenerative medicine specialist, and believe it or not, fat has a couple other properties within the body other than simply storing additional calories. So if we look at fat tissue, and people hold on to fat tissue in different places in their body, but there's elements of fat tissue that are actually very beneficial for healing orthopedic injuries. I want to discuss that in today's video because in other videos I've talked through things like prolotherapy. This is like, we'll call it ancient times, 1930s, 1950s regenerative medicine. And then PRP came on the scene in the 1990s. And if we really look at mFAT, it was probably around 2009, 10, so that came on the scene. When I use the term mFAT, we're talking about microfat. So micronized fat, and there's another version of that, if we refine fat down even smaller, called nanofat, just based on the size. And if we take that down even further, we get a fraction called stromal vascular fraction. And that's where people that, kind of look at what is the substance within our fat, say that fraction over here probably has a significant amount of stem cells. And if we look at stem cells in the body, stem cells are the master repair cell in the body. So we have stem cells that exit our bone marrow. So I have this handy dandy model. If we look inside the bone, this is bone marrow. Okay, this is where all of our blood cells are made, including stem cells. So inside the long bones of our body or the pelvis, we have stem cells. Okay, we're born with a certain amount of them. They can replicate over our lifetime. And then eventually they fizzle out and die. And that's part of why we age and decline as we age, is stem cell exhaustion. But if we look at stem cells in other places of the body, we actually house some stem cells, believe it or not, within our fat tissue. Not all of our fat is stem cells. So those of you that are carrying a little extra around, it doesn't mean you have a plentiful amount of stem cells on you. It means that a fraction of those stem cells are stem cells. Okay, and a fraction of that fat is just fat storage, fat cells. But if we were to take a graft of fat very easily and through a very simple in-office procedure, we can numb up a little bit of an area where you have fat, extract some of the fat, like a mini liposuction procedure, which I didn't think I'd ever be doing in my practice, but now I am. But if we take this fat and we process it down through a mechanism of what we call minimal manipulation, which is what we're allowed to do with this tissue, according to the FDA, we can get an injectable form. So instead of having this big globs of fat, it becomes almost a gel-like injectable type of product. And where might this be very beneficial to people is when they have a larger tear. So if I take a shoulder model, which I have over here, and we talk about rotator cuff tears, a couple of the early applications of this, they started to look at if people partially tore this tendon. So if you completely tear this tendon off the bone, you're probably needing surgery. If you say you're sub 60, if you're older than 60, what the data shows that we can still repair those things, my surgical colleagues, but there's a high failure rate of that surgical fixation where they might tear this thing again within a year. So the trade-off of going through a surgery, rehabbing it for many months, not using your shoulder, and then re-tearing it is kind of a bummer when that happens for people. And then what do you do? So they started to look at maybe there's a different mechanism we could use, because when we tear this tendon, if we look at it this way, there's a width of the tendon coming across the tendon. There's also a thickness of the tendon. So when people have partial tears of the tendon, say in the rotator cuff, it could be a partial thickness, not the entire thickness, and it could be a partial width tendon. And then in front and back of that tendon, you have other sandwiched tendons, front and back. So it creates this hole or this gap. And so what we're always analyzing on an MRI is how big is the tear? Okay, so thickness of the tear. What's the width of that tear? And then is there retraction? So if a fragment or a section of that tendon tears away, is there a retraction? So if you're reading your own MRI report at home, following along, okay, thickness of the tear, width of the tear, retraction. You may see some things like that on your report. And based on that, when we see these things that are, say, sub-centimeter tears with retraction, what they started to do is take this fat graft, and that's what we call it, and we could engraft that little hole. So if I can take this hole in the tendon and I can fill it up with fat, okay, it's not going to take the tendon fibers that have torn off and retracted and bring them back over here and anchor them back down to the bone. but we can fill in this space, much like spackling the wall over here, with a hole and make that structure stronger. Okay, so it would give more integrity to that tendon complex of the whole rotator cuff. But again, I want to be clear. It does not take the torn tendon fibers and mend them back together over at the bone. The only thing that can do that is surgically trained hands from your neighborhood orthopedic surgeon who is trained to repair tendons. So sometimes if it's a massive tear, that's the best way to go if you're a young athlete and you want a very stable shoulder in time. But if you're an older athlete, if the prospect of surgery doesn't sound exciting to you, then this is where we're using mFAT very commonly as a grafting material. And we use these in the gluteal cuff. So a lot of people, second most common area I'm using this in my practice is people that are told they have hip bursitis, side of their hip pain. And it's not actually bursitis, it is a form of a cuff tear. So if we think about the bony knob on the side of your hip and all these muscles that come in from the hip and the glute and attach here, we can get these partial tears as well in the hip. And I see that very commonly. Treated a gentleman yesterday with this very injury. So again, we engrafted that, first seeded that area with some growth factors from PRP, which is platelet-rich plasma, which I talked about in another video, so you can find that one. We use this combination of infilling that with some growth factors, and then we infill that with that grafted, that graft material from the fat, and seed it some more with PRP. And these can really heal nicely over time and be stronger and far less painful for that patient. So, you know, it's a little short take on fat and why we use it, why your fat may be useful to you orthopedically, in the right situation, in the right hands with somebody with the right training and technique on this. It can be a very nice option if, one, you're trying to avoid surgery, or two, you've been told you don't have a good surgical prognosis, and you've tried physical therapy, you've tried modification of activities, and you're just struggling with shoulder or hip pain. mFAT could be a potentially really awesome thing there treatment-wise. And the final point on this, if we look inside the knee, you know, there's applications of this now where they're really looking at installation of this micronized fat into the joint itself. There's an Italian study published on this this year, and it was a 4-year follow-up study where very nicely done, where they scoped the patient arthroscopically so they could look at the extent of damage in the cartilage, grade it, then they gave them an injection of this mFAT material, and then they followed them forward for many years. And at the 4-year follow-up, which was this year, published this year, 2024, they showed that almost 70% of those patients were still having really good results from that procedure. And now they're going to follow them out another 4 years to see how did that shake out after over 8 years. So I think if we had something that worked that well from a medication or pharmaceutical standpoint, that one treatment could last potentially 4 years or longer, I mean, that's really something quite remarkable, which is what this can do. And really what it's leveraging is the remarkable healing capacity of the body. And really that's all we're doing in regenerative medicine, is leveraging what your body does for you, resupplying the area that it needs those cells to stimulate it to heal. And then it's your job to take care of yourself, get the sleep you need, get the nutrition you need, and try to de-stress that area that needs time to heal. And a lot of these injuries can heal. So that's my take on mFAT and why I use it in an orthopedic practice like mine to take care of people with shoulder and hip issues and other injuries. So if you like content like this, click the like button so I can make more. If you want to see our new releases of content like this, subscribe. And if there's something I missed on this topic that you've heard about and want to know more about, drop it in the comments so I know, A, somebody's out there watching this. 2, if there's something I missed that I can help you understand better, well, that's my job, is to build some content to help you understand the options you have available to you to take care of your body in the way you would like to. And speaking of that, if we can help you in any way in my practice, in the notes below, you'll see a link over to my practice where you'll fill out a few questions about the situation you're dealing with. And if we can help you in any way, that's what we're on the face of the earth here in the practice at Origen to do.